Well, hello. It's a pleasure to be with you today at the conference, and it's a great opportunity to discuss a big issue that's happening in healthcare, price transparency. It's something that's been discussed a lot in public policy circles and the media and others, and it's something that we have a great guest here today, and someone who's been looking at this for a long time, and other than Dr. Deane Waldman will be joining me soon to kind of go over his thoughts on price transparency, what things should look like in the marketplace in healthcare, and then we're going to have a good discussion afterwards. So you don't want to miss that. It's going to be a great discussion overall. My name is Dr. Vance Ginn. I wear a lot of hats, but I'm president of Ginn Economic Consulting. I was the former chief economist of the Office of Management and Budget at the White House for a year from June 2019 to May of 2020. And I've worked on healthcare policy here and there. And it's also a big issue, of course, as we know. It's a major sector of the economy. It's a massive part of the federal budget, but also state budgets. And then, of course, it influences all of our lives. So it's something that we need to have a better understanding about overall. So for Dr. Deane, though, let me give you a brief bio of his. I could go on for a long time, but let me give you a brief bio, and then I'm going to kick it over to him. So Dr. Deane Waldman is the author of Curing the Cancer in the United States Healthcare and 11 other books, as well as more than 250 articles and monographs. After nearly 50 years as a pediatric cardiologist, educator, researcher, medical administrator, and public policy advisor, he is in a unique position to inform us about what's happening in healthcare, what things look like today, and where we should be heading in the future. So, Dr. Deane, it's a pleasure to be with you today. I know you're going to give a great presentation on why price transparency won't work, but it could work if. I think that really leaves us guessing what you're going to say. So I'm going to kick it over to you now, Dr. Deane, and have at it, and then we'll come back and we will have a good discussion afterwards.
Thank you, Vance, and it's my pleasure to be with everybody today. I'm going to explain why price transparency won't work to make healthcare affordable, at least not the way healthcare financing is currently structured. Later, little foreshadowing, I will share with you how price transparency could work if the financial structure were changed. After I give this formal presentation, Dr. Ginn will show us what I got right and where I went wrong. Before we start, let's agree on terminology. Always, every debate you start with, what are the terms? As one word, healthcare refers to the system, a massive structure that consumes nearly 18% of our GDP and involves every single one of 322 million Americans. Health care, as two words, is the intimate, confidential, legally protected fiduciary relationship between one patient and one doctor. Price, or charge, same thing, is the money a seller expects to be paid and wants to be paid. Payment is what the seller actually gets. And obviously, cost is all the resources, money is only one, there's also time and materials necessary to produce a good or a service. I know that's obvious, but I want to make sure we're all on the same page. As a second prologue, I want to prove to you that healthcare and health care are both unaffordable. Last year, the U.S. healthcare system expended $4.5 trillion on its healthcare system. That one expenditure is more than the entire GDP of the fourth most productive nation on earth, namely Germany. 4.5 trillion is nearly double what other comparable nations like Great Britain and so forth expend on healthcare. Former President Obama was right when he described the U.S. healthcare spending curve on healthcare as unsustainable. If we keep this up, we're all going to go broke. Health care, the service, is equally unaffordable for the vast majority of Americans. In 2023, median household income was $75,143. Healthcare expenses totaled $31,065, of which, now this is important, of which 23,968 was compensation the employee did not receive, but rather was given by the employer to an insurance company to purchase health insurance for the employee. The employee paid $7,097, or nearly 10% of gross income, on copays, deductibles, and drugs not covered. To explore price transparency, let's use the standard approach from a logical theory, namely thesis, antithesis, and synthesis. Propose an idea, show countervailing data, and then resolve the differences into a synthesis. Our thesis is, obviously, price transparency can make healthcare affordable. The antithesis is price transparency cannot make healthcare affordable. And obviously, the synthesis would be if financing were restructured, price transparency will make healthcare affordable. Now, the Centers for Medicare and Medicaid Services, CMS, everybody knows that abbreviation, has promulgated rules that mandate price transparency in healthcare. Most of these rules, I've read them all actually. Oh, talk about going to sleep. Most of these rules start with the same sentence. Hospital price transparency lays the foundation for a patient-driven healthcare system by making hospital standard charges available to the public and supports President Biden's executive order on promoting competition, end quote. Please keep those words that are highlighted or in yellow in your mind. The first round of price transparency rules apply to the following: hospital inpatient and outpatient services, ambulatory surgical centers, inpatient rehabilitation and psychiatric installations, as well as skilled nursing facilities. Eventually, Washington intends to apply their price transparency rules to all forms of medical care delivery, down to the solo practitioner, if we have any still left in practice. To give you a flavor of these rules, here are some direct quotes. The federal government will be enforcing price transparency of standard hospital charges. What will be made transparent is a list of the hospital standard charges for items and services. When a hospital is not compliant, the maximum penalty could be over $2 million for the largest hospitals per event and may be imposed without warning. That's a direct quote. There will be additional enforcement process changes to increase compliance. Finally, mandatory price transparency will require standardization of format and data elements. Next, we come to the antithesis, the 4 reasons why price transparency won't work. First is the fallacy of price or charge. In healthcare, price is a highly variable number with different charges for the same procedure in various parts of the country. More important, price is not what the seller is paid. Price is not payment, as it is everywhere else in every other market. Let me give you an example from my own experience several years ago when I was doing cardiac catheterization procedures in critically ill newborn babies with congenital heart disease. The standard charge for my professional services before, during, and after the cath averaged around $2,500 at New Mexico Children's Hospital. At Texas Children's, the average charge for the identical services was $4,000. Medicaid paid both of us its maximum allowable reimbursement for that care, $387. Now, if hospitals publish charges as mandated by the price transparency rules, patients would get a wildly inflated impression of what doctors are actually being paid. Reason number 2, Price transparency won't work given the structure of the healthcare market. It is centrally controlled. It is not a free market at all. In the everyday free market, there are two parties and only two. There is a buyer, who is also the consumer and also the payer. And there are multiple sellers competing for buyers' dollars. The buyer decides what to buy, from whom, at what price point, and pays the seller's price out of personal funds. The seller provides goods and services in exchange for the buyer's dollars. If one seller's offering is too expensive, inferior quality, or delayed in delivery, the buyer simply goes to a different seller. Sellers compete with each other for buyer's money. Price equals payment. Healthcare has a market that is unique. There are three parties, not only the usual two. The third party makes all decisions that are normally made by buyer and seller. Technically, third parties are insurance companies, health plans, and Medicaid. However, Medicare. Medicaid works through insurances. Medicare. However, all of these third parties must abide by federal rules and regulations, so the Washington bureaucracy is really the final decision maker through its rules and regulations in healthcare, and not your insurance company, not your health plan, not the patient, and not the doctor. As the third party, Washington takes healthcare dollars out of Americans' pockets and distributes them as it sees fit, paying itself first, and we'll get to that later. By regulating insurance benefits and releasing medical mandates, Washington tells care sellers what care they can provide and what care they can't. In market terms, U.S. healthcare, this is for the economists in the audience, U.S. healthcare is a federal monopoly as well as monopsony, one buyer and one seller. That is a centrally controlled economy, just like the USSR. And just like the USSR, we have shortages, low quality, wasteful spending, and exceptionally long wait times for care that lead to death by queue, and I'm going to emphasize that. Well, today's presentation is about financing. As a physician, I simply cannot leave unsaid the medical consequences of the third-party payment system, death by queue. People are dying while waiting in line for technically possible medical care that doesn't arrive in time to save them. We all have seen pictures of Russians waiting in line for things like toilet paper and shoes, and especially medical care. We certainly don't expect to see Americans in such wait lines, but sadly, it has been reported here as well. Americans wait too long to get care, and we too are experiencing death by queue. Here are some examples. Medicare refuses to approve many life-saving but highly expensive drugs by labeling them experimental. As a result, many cancer and heart attack patients do not receive the best care and die who could be saved. Medicaid has death by queue. For example, 752 people who were identified by reporter Nick Horton in just one state, namely Illinois, in 1 year. Then there was Diamante Driver, a 12-year-old boy in Prince George, Maryland, who died from a cavity. Yep, I said a cavity in his tooth. There are no pediatric dentists in his area who could afford to accept Medicaid's low reimbursement schedule, so his cavity went untreated until the infection spread to his brain, causing a brain abscess from which he eventually died. It's hard for me to say what I'm about to say. Medicaid also has death by Q for our veterans who are in TRICARE. After they risk their lives on foreign soil, they come home to face a greater risk. The risk of trying to get medical care in time to save themselves. According to an internal VA audit, quote, 47,000 veterans may have died waiting for care, end quote. For comparison, 47,000 veteran deaths is 7 times the number of American military casualties in war-torn Middle East over the past 20 years. Such documented death by Q is incontrovertible evidence of the failure of the U.S. healthcare system. The third reason for price transparency failure is the most obvious. Patients don't choose the hospital or the provider based on choice. They don't choose at all. The third parties do. Patients can't reduce their spending behavior because they ain't the spenders. After the fallacy of price, after the lack of a free market, and after buyers who aren't spenders, the final reason that price transparency won't make healthcare affordable is what I call Barcom. Every piece of legislation passed by Congress, such as price transparency, is implemented using Barcom, an acronym that lists all the activities required between passing a law and Americans experiencing its effects in everyday life. First comes the legislation or executive order that establishes a mandate. A bureaucracy of people must be hired, and of course, they need compensation, buildings, hardware, software, disposables, and sundry. Based on the mandate, rules must be written, followed by specific regulations that are actionable. An administrative structure then becomes necessary to connect these regulations with the people who are impacted. Shown here is the organizational chart for the Affordable Care Act. Who reports to whom, who is responsible for what, how many people are on staff, et cetera, et cetera. Think about the cost of this, Barcom, and then add all the federal agencies involved in healthcare, such as CMS, IRS, FDA, NIH, EPA, AHRQ, HRSA, EPA, OSHA, and those are the ones that I could come to off the top of my head. There are many more. The final elements of Barcom include compliance officers who must be hired to assure that affected entities understand the regulations and the reporting requirements. Others must oversee, review, and assess to assure that people actually comply with the new regulations. Finally, someone has to enforce penalties on those who are not compliant. All of this Barcom costs money, lots and lots and lots of healthcare dollars. In fact, it is estimated that as much as half of all U.S. healthcare spending pays for Barcom. That's $2 trillion of federal healthcare spending, quotes around healthcare, that is not spent on health care. Now, where, you're going to ask, is all this money going? Here's your answer in one graph. I call it the graph. This chart displays expansion of the healthcare workforce over 40 years from 1970 to 2010. The flat green line on the bottom, shown by the green arrow, documents a 100% growth in the supply of physicians over those 40 years. During the same time period, the number of healthcare administrators, people who provide no patient care, expanded by more than 300%. That, of course, is a black arrow. And this graph doesn't even include the bureaucrats and bureaucracy added, and Barkham added by the ASA, which was implemented in 2014. Now, who are these people inside Barkham whose salaries come first before a single care provider gets paid? They are accountants, actuaries, agents, consultants, reviewers, billers and coders. I bet you didn't know that the third largest department in every hospital in the country is billing and coding after nurses and doctors. There are administrators, managers, lawyers, lots and lots of lawyers, compliance officers, and then, of course, there's fraud and abuse. What is left after all these people get paid goes to those who actually provide care for patients. Now, ask yourself this. How would patients, knowing the prices, change bureaucrats' spending behavior? Despite all this, depressing data, there is hope. A synthesis is possible. It is to make price transparency work. It is called patient-controlled healthcare. To emphasize what is really important, critically important, who has control of decision-making? And the answer is the patient. There is no ambiguity, no confusion. Patients decide how to spend their money and what medical care they will get, period, full stop. The key is removing the third party as decision maker. Buyer and seller can interact directly with no one and nothing in between them. Note, this must be done by the public at the ballot box. Federal politicians will never voluntarily give up the incredible amount of power they currently wield via their control of the healthcare system. By removing the third party as decision maker, buyer, also known as patient, can reconnect with seller, also known as provider. Patients can make decisions that affect them, both financial and medical. In a patient-controlled healthcare system, market actually, a seller must price his goods and services knowing that other sellers will compete with him for buyers' dollars. Buyers choose sellers based on the buyer's determination of price and quality, not based on federal allocations. Price equals payment. Price is determined by the market, not fixed by allocation, by allowable reimbursement schedules. Buyers pay sellers out of pocket, or more likely, out of a large family HSA. With patient-controlled healthcare, prices are necessarily transparent. There's no need for federal rules or any Barkham for that matter. Price is once again the signal between a buyer and a seller that balances supply and demand. When healthcare is patient-controlled, Americans will have high-quality, affordable, timely healthcare. Now, how does this work at the ground level for the individual patient? Okay, first, household income becomes $99,111 because the employer pays the employee that $23,968 instead of sending all that money to an insurance company. The employee puts that money into a tax-free, no-limit HSA every year. With tens of thousands of dollars available, the family simply shops for their care and pays for that care out of the HSA. Patients will simply not go to providers who do not advertise their prices, whose prices are too high, or whose service is simply too slow. For the very expensive, unanticipated heart attack or cancer diagnosis, the family takes the $7,097 normally used for copays and deductibles and buys very high deductible catastrophic medical insurance. And finally, for those who are medically vulnerable, there should be medical safety nets, but these should be designed and operated by the states without any federal involvement other than returning to the states those tax dollars currently earmarked for Medicaid. You can see several examples of different forms of state specific medical safety nets with the financial models in my book, Curing the Cancer in U.S. Healthcare. State-generated medical safety nets work much better than one-size-fits-all Medicaid and are much, much cheaper. More than half the U.S. population has health coverage by the federal government. Medicaid or CHIP with 85,800,000 people, Medicare with 65.8 million enrollees, 9.5 million in TRICARE for the military, and the uninsured 27.6 million and rising dramatically due to illegal immigration, who receive medical care free by the EMTALA law, the Emergency Medical Transport and Labor Act of 1986. 43% have employer-supported health insurance, which is a stopgap measure during World War II because of wartime rationing. This measure has never been reversed and clearly should be. This obsolete holdover law from 80 years ago gives Washington control it should not have and distorts the entire healthcare market. As for the nearly 86 million Americans enrolled in Medicaid, Washington is in direct contravention of its own law. Now, that is fact, not opinion, and I'm going to prove it. On this slide, I have copied Section 1801 of the Enabling Medicaid Law from 1965. The reference is provided below just for proof. Quote, nothing in this title shall be construed to authorize any federal officer or employee to exercise any supervision or control over the practice of medicine or the manner in which medical services are provided, or the selection, tenure, or compensation of any officer or employee of any institution, agency, or person providing health services, or to exercise any supervision or control over the administration or operation of any such institution, agency, or person. Quite obviously, this was written by lawyers for lawyers. It is clear that Washington has chosen to ignore the rule of law, its own law. Federal officers or employees currently control the practice of medicine, supervise compensation, and administer state Medicaid programs, which they were strictly prohibited by their own law from controlling, supervising, or administering. Patient-controlled healthcare is what the U.S. desperately needs. It is the only way to rule in out-of-control healthcare spending. It will produce the magic of the free market with the best care for the most people when they need it at the lowest possible cost, both for American families and for the nation. With patient-controlled healthcare, almost all of today's wasteful spending will vanish. We can recoup most of the $2 trillion currently taken away from patients and either spend it on care or reduce the tax burden and put it back in American wallets where it came from. Medicare can and should be paid out before it goes broke, which is less than 5 years from now, and let those who put money in transfer that money into their HSAs. Medicaid and the ACA should simply be repealed as unnecessary regulatory overreach. And for the medically vulnerable, the states can and should develop their own safety nets sensitive to the specific needs of their state's population. Let me conclude with a current third-party payment structure. Price transparency will fail to improve healthcare finances and will, in fact, increase healthcare spending. If the U.S. healthcare system were structured as a patient-controlled healthcare system, price transparency could produce affordable, timely, high-quality medical care. And that's it. And I would love to turn this over to Dr. Ginn so he can show me where I got it right and where I got it wrong.
All right. That was a good presentation, Dr. Deane, and a lot of good information, things for us to think about. And I do have some questions for you in the about 10 minutes I think we have available here. When we're thinking about the marketplace, and I think you're right that the government is such a large part of this system, the market can't really work when you think about supply and demand and the contribution to that, to the price that's there, the cost that we're paying in healthcare. It makes it very difficult to think about how price transparency would work. But when you're thinking about this from those who really believe strongly that price transparency will influence people in the marketplace and help those to at least see what they're paying. I mean, it's frustrating when you go to the doctor or go to the hospital, you don't really see what the amount is, and usually that's because of the redistribution rate or the reimbursement rates that they have set behind the scenes that we don't really get to see. So then they bill us later. And so it would be nice to be able to see what that amount is and look at the price and say, you know what, I want to go to this doctor or that doctor. But why can't that work? Just putting a fine tune to what your view is on this. Why won't that work to help the marketplace react in such a way that really brings doctors and patients closer together?
And the answer is really kind of simple, and that is for price transparency to reduce spending, which is what we're talking about, not cost. Cost is, the number of resources necessary to do whatever it is you're doing. But the actual spending, for price transparency to reduce spending, it has to affect the spender. And the problem is the spender is really not the patient. In other words, I don't choose as a physician, as a patient, I don't choose to go to a hospital based on its price because A, my health plan tells me what hospital I have to go to. I don't have a choice. And B, whatever their charge is that they're going to publish, I don't pay that.
Mm-hmm.
My insurance does. And it pays a hell of a lot less than what I see on this thing. So I'll see this charge for $25,000, or actually average charge for a hip replacement. This is in the book. Hip replacement is $35,000 some odd dollars for insurance-based healthcare. In a direct pay, patient-controlled system, the actual price, the charge, is $12,000. And so my point is, as a patient, I see $35,000 for that hip replacement, and I think that the hospital or the doctor is getting paid $35,000. But that's simply not true. And by the way, I'm not paying that $35,000. I'm paying my deductible of $1,000 or whatever. And so price transparency won't change anything.
Yeah, and you still have the middlemen that are in the way that's influencing the market and not allowing us to see what that is, what the price is, and how much we're spending. I think that's a great point.
What the payment is.
Right. But that's such a key point because we're not seeing exactly what the cost is. And even if we were, as a consumer, if I saw how much that cost was compared to the reimbursement rate that I'm likely to see, I don't know that would have much of an influence on the marketplace. But true. One thing I would think about here, though, is, in general, I think I like a lot of the places where you're heading with this, with more HSA money compared to Medicare, putting more of the power in the hands of the consumer versus the third party, the indirect payment through Medicare and government taxpayers, really. But that may be a ways down the road, right? And maybe we won't get to the situation where we can replace or repeal Medicaid and Obamacare and things of that nature. So we're left with the institutional framework, for better or worse, that we have today. What are some other steps then to get to a situation that we have better access to quality care and timely quality care compared with some places want to, or have, many states have already expanded Medicaid. Texas is not one of those where we're both located. And I don't think they should, but a lot of states have already done this. And so I wonder, without some of these major policy changes, what are some other steps that might be taken to get to a situation where you do have a better connection between the doctor and the patient?
All right, 2 points in response. Number one, this doesn't sound like an answer, but it is. So, but let me say, there is the seesaw effect, and I've written about this quite a bit. And it's very important that people understand that when you're talking about expansion of Medicaid through Obamacare, and that is the following: as more people are enrolled in free government insurance, free. I know you complain all the time about the word free. I'll rephrase: in no charge Medicaid, as the number of enrollees goes up, the wait time also goes up. In other words, access goes down. So people are getting this false impression that as more people have insurance through the government, they actually get care, when in point of fact, the more people who enrolled in Medicaid, the longer they wait to find a doctor, or, as you know, that dental story I told you, people literally can't find a doctor. Now, what can we do with the current system? The answer is we really should change the system, as I've said. But one thing we can do is we can essentially demand change in the HSA laws so that, number one, they become unlimited. You can put as much money as you want into an HSA. And number two, that they roll over, that they are essentially eternal in your family. Now, the reason that's important is if you've got some real money in an HSA, you can go to a direct pay doctor or a concierge doctor instead of going to, I wanted to go to a concierge doctor. Here's a direct thing. I wanted to go to a concierge doctor and I wanted to put some real money in my HSA. I found out that the only way I can do that is if the health plan that I'm enrolled in has that I have a very high deductible, and the health plan doesn't have that. In other words, I can't put more money into an HSA. My point is, one thing we can do right now, we can say, hey, you can put as much money as you want into an HSA, and you can keep it indefinitely. It's tax-free when you use it for medical care, and go shop for your care.
Yeah, that makes sense. And what about direct primary care? Do you have a view on that, if that's a good step in the right direction or not?
I feel so strongly about that. I have a number of people whom I know who have started this, both direct pay primary care and direct pay surgical care. Keith Smith's center, now there are a whole bunch of them. There are actually 4 of them here in Texas, where they are charging a small fraction of the insurance charge for cash only healthcare. Bottom line, I'm a big fan of anything that is direct pay, namely that the patient pays the doctor without a middleman. And by the way, when you asked about stuff that needs to be done, I keep coming back to that $2 trillion that is being wasted on the regulatory structure. I mean, people don't understand. Half of all of the money they call healthcare spending doesn't produce any care.
Yeah. Yeah, it's mind blowing whenever I saw that number from your work. And, I think another key part of your view and your approach on the reforms that are needed is basically based on federalism, right? This laboratory of competition that we have available out to us to basically devolve the centralization that's happened so much over time to the federal government, whether it be from 1965 reforms of Medicare and Medicaid and then Obamacare. There's just been a lot of more centralization that's taken place. But a lot of those at the federal level, I was at the federal government for a little while, they'll be cautious about devolving that back or to the states. And
No, they don't.
I wonder
They don't
how we
wanna
should get
do that.
started with that, though. Because I think it's
They
a great
don't wanna
idea.
do
Just
that.
yeah,
I'll give you a great example, right? And I've been involved in attempts
Yeah.
at legislation for work requirements.
Mhm.
Okay, why should the government tell a state that they can't have work requirements for Medicaid?
Yeah.
Now, I'm not saying I happen to think that work requirements are a good idea, but that's not the point. The point is, why can't the state? I mean, remember Section 1801. The state should be able to design, administer, and implement its own system of whatever their medical safety net is. That's the law. So if one state wants a work requirement for people on Medicaid and another person doesn't, and another state doesn't, why should the federal government say no? And the answer is they shouldn't.
Mm-hmm.
So you're right. Federalism is a way to connect, get better connections within the market, basically.
Yeah. It's a great point there. And I mean, look, overall, great presentation. There's a lot of things to think about when we're looking at price transparency. And ultimately, in a marketplace, prices are what send the signals to the buyer, the consumer, and the supplier, the doctors in this situation. And unfortunately, that's not the way the system we have today. Too many distortions, too many middlemen, too much government, third-party payers. It's not the doctor and the patient. And so it's something that we really got to tackle if we want to tackle healthcare. As we're wrapping up here, Dr. Deane, what else would you want to leave us with as we close here?
I think we need to take a good hard look at the promises that are being made by federal politicians and say, wait a minute, you promised me, President Obama is a good example. He promised all the care that Americans need. What we got was a lot of government insurance. We need, as people at the ballot box, to say, hey, you promised me whatever. Where is that whatever?
Mm-hmm. Yep. Okay. Well, it's been a great discussion, Dr. Deane, as always. It's a pleasure to be talking to you today about your price transparency. I hope the audience will have a lot to think about and talk about, and hopefully get some reforms moving in the right direction in the future for a way for price transparency to work within a real market, within a real marketplace here in healthcare. And so with that, again, I'm Dr. Vance Ginn. This has been Dr. Deane Waldman. Thank you for joining us today and enjoyed the rest of the conference.